last one in this section is intra and inter-reader variability of transvaginal ultrasound bladder wall thickness measurements, results from the shrink study, and that's going to be presented by Andrea Tubaro.
Madam Chairman, Mr. Chairman, good morning. It's a pleasure to be here to present. These are my conflict of interest. It would be nice. Okay, so the study comes from, it's a sub-study of the shrink one, and looks at the variability of bladder wall thickness measurement in a large international study. A number of studies in the past have shown that the measurement of bladder wall thickness in women can be used as a diagnostic tool to identify patients with detrusor overactivity and overactive bladder. The shrink study is a study investigating the effect of solifenacin in patients with detrusor overactivity and OAB symptoms, looking at the possible change in bladder wall thickness measured before and after administration of the drug. This sub-analysis has been devised to look into the intra- and inter-observer variability in a different setting from the single-center studies that have been used in the past years. This is the study design of the shrink. It's a phase 4 double-blind randomized placebo-controlled parallel group study. Over 600 patients have been screened, and 547 have been randomized to, in a 1-to-1-to-1 fashion, to either solifenacin 10 milligrams or solifenacin 5 milligrams or placebo. Patients were treated for 12 weeks. Blood wall thickness has been measured in the way that has been always suggested. So patients must have an empty bladder, less than 30 milliliters. The thickness was measured at the dome, the anterior wall, and the trigon. And the three values were averaged. Images were considered readable if at least two sides of the three could be read by an independent reader. In order to look at the intra-reader variability, the three readers were blindly submitted to 40 different images at two different time points. And obviously, the difference in the measurements were calculated. For inter-reader variability, we have over 1,500 images that were assessed by two central readers who were blind of the treatment arm and of the time point of the study. A third reader was asked to review pictures in which there was a large difference between the measurement done by the two central readers. So the third reader only looked at a subset of the 1,500 pictures. And obviously, the mean differences in measurement were looked at. Now, let's look at the intra-reader variability. It was between 75 and 85% of images. The quality was good, and we had an intra-reader agreement, which was relatively high. Only reader 2 had a significant difference in the mean blood wall thickness measurement between the two measuring sessions. So these are the data for reader 1. You see there is very small difference between session 1 and session 2. Reader 3, again, different values, but very little change between the two sessions. But reader 2 had a significant change between the first and the second session of measurement on the same picture. So two readers were highly reliable, and in one case there was a significant difference. Let us look at the different locations, because we have said bladder wall thickness was measured in the anterior part of the bladder at the trigon and there's a dome. If we look at the trigon, reader 1 and 3 had smaller values for bladder wall thickness at the trigon level, which is somehow opposite to what many people would expect. We know from many studies that the trigon thickness is supposed to be equal to the anterior or the dome, but for reader 1 and 2, it actually seemed to be smaller, but not for reader 2, in which the same values were given for dome, trigon, and the anterior wall. Looking at now at the inter-reader variability. On over 1,500 pictures, reader 1 and 2 were in agreement in over 91% of cases. The mean difference was between the two central readers was 0.4 millimeters on average. And sometime we could see a systematic reader effect because, for example, reader 1 tended to give lower measurements, lower values than reader 2 in a systematic way. If we compare the readers, these were the two central readers, reader 1 and 2, and as I said, it's 0.391 millimeters difference. The largest difference has been between reader 1 and 3, but again, there was a sort of systematic tendency for one or two readers to read smaller values. If you look at readers 2 versus 3, again, it's 0.3 millimeters difference. So in conclusion, the intra-reader variability seems to be, generally speaking, low. The mean difference between sessions was statistically different only for one of the three readers. For reader number 1 and 3, there was no significant difference in between two different sessions on 40 consecutive images. While as far as the inter-reader variability, we have to consider that reader 3 only had access to those pictures in which there was a significant difference between reader 1 and 2, so we only evaluated a subset of it. But we have seen that the trigon tended to have a smaller value of thickness compared to the anterior part of the bladder and the dome, but generally speaking, seems like measurement on ultrasound of bladder wall thickness in women is a reliable measurement and can be used in for clinical purposes. Thank you.
This paper is open for discussion, but Andrea, whilst it wasn't actually the topic of this presentation, have you been able to show that central reading is more accurate than the clinician taking the measurements himself in real time?
Well, we all start our research intramural at our department in our site, and most of the times what we do at our place works. But in order for any diagnostic procedure to be used, it has to be confirmed. So the big difference between everything that has been published until now and the result of this study is that this is methodologically sound because it comes from a multi-center international study in which the measurement was done in many, many different sites, but the reading was done centrally. Obviously, for the sake of methodology, central reading is absolutely essential. The problem is that what we take back from this study is that the central readers should better be tested before initiation of the study.
Yeah. Hans-Peter.
Could I support what Andrea just said? It's great that you did such a study, and it's an example to all of us how to handle the validation of a method before you take it to a multi-center application. That's great. Thank you very much for that. There's just one result that puzzles me a little, and I wonder whether that's partly due to the methodology of transvaginal ultrasound for bladder wall thickness. Because you see, when I measure bladder wall thickness translabially, the trigone always seems thicker. The trigone always seems thicker than the dome. Unless you've got somebody who's got a hypertrophic detrusor with a DWT of 10, well, then of course it's the dome, not the trigone. That hypertrophy is more. But normally the trigone is thicker than the dome. So I wonder, is that an artifact of a slight distinction by the head of the ultrasound probe, or how do you explain that?
Hans-Peter, this is hard to explain. What I have shown is what came out of the study. I couldn't agree more with you. Even if you look at the pictures that I had on my slide, the trigone seems to be thicker. But for reasons that I cannot explain, in the study, it turned out to be thinner. This brings all of us back to the problem of how to validate ultrasound measurement. Because in any other diagnostic study, you have to validate your technique of measurement versus a gold standard. Now, there are different gold standards. In the old days, Kojima, who was the one who started a long time ago in Japan with blood wall thickness measurement, he did comparison with cadavers. And he said that the blood wall thickness is the same all over the bladder, which may be contrary to our intuition or our ideas, particularly as urologists. But this is what anatomy said. Now, we don't have comparative studies between CT scan and ultrasound on blood wall thickness, but I agree with you, we still have to give a definitive answer whether the trigone is as thick as the rest of the bladder, thinner or thicker.
Dr. Tubaro, would you please emphasize the place of bladder wall thickness in the evaluation of the OAB patient and also in the assessments of the efficacy of the treatment, please?
Well, this is a little bit beyond the scope of this talk. There is a poster at this meeting on the results of the shrink study. Measuring blood wall thickness, we know in different areas, both in men and in women, blood wall thickness can change with treatment. Although I have to say that measurement of blood wall thickness is, at least for now, mainly used for diagnostic purposes. It can be used in clinical trials just as a proof of concept, but there are many other ways to understand whether the patient is responding to treatment. What we were looking at was whether there was an anatomical change due to pharmacological treatment, which is something obviously of interest, but certainly not for daily clinical use.
Well, thank you very much to all the speakers and to you, the audience. It's coffee time, and you'll be resuming at 11 o'clock.